I am so pleased to introduce Dr. Hilaire Thompson. She is a registered nurse and nurse practitioner with over 30 years of experience in the clinical care of persons following a traumatic injury across the continuum of care. She's a professor and executive dean at the University of Washington School of Nursing. Her research is focused on primary prevention of injury and improving functional outcomes following traumatic brain injury in older adults, with a particular emphasis on fall prevention. As core faculty at Harborview's Injury Prevention and Research Center since 2008, she has a long history of designing and conducting extramurally funded studies, including a current study adapting and testing the STEADY toolkit for long-term care and skilled nursing facilities. Welcome, Dean Thompson, and you're in for a treat, everyone.
Thank you, Dr. Cochran, for the lovely introduction. And I'm happy to talk to you about one of my favorite topics, traumatic brain injury in older adults. So just disclosures, I don't have any conflicts of interest. And as Barb mentioned, I currently have grant funding support from the National Institutes of Health, as well as the Centers for Disease Control and Prevention. I have three objectives for today's talk, specifically looking at trends in geriatric TBI prevalence and also what the causes are, looking at aging-related changes that can influence both injury in the first place as well as outcomes following injury, and then talk about initial care and symptom management for older adults with a traumatic brain injury. I just wanted to start by anchoring the conversation and why I care about this a lot. As Barb mentioned, I've been a neuroscience registered nurse for over 30 years. That was my first job out of nursing school, was working on a neurosurgical unit. And I just really fell in love with the population in the sense that when you see one brain injury, even if it's very similar to another, you've seen it because individuals are different and the way their brains are wired are different. And so it's just a really fascinating, wonderful population to work with and to help foster their recovery. When I went into my PhD program, I was studying something called neurogenic fever, like basically fever after head injury as a topic. When I was in my my doctoral program and had just finished up, my mother, who is pictured here on the left, was visiting Rome with her church group and ended up falling down a set of marble stairs and suffered a traumatic brain injury herself. This was the first time that really it intersected with outside my clinical world with my personal world. And I think like most good researchers or clinicians, you look to what the literature says to do for the person and just want to make sure they're getting the best care. What I realized at the time was that, and this was about 2008, is that there wasn't much literature at all on what to do for older adults with a brain injury, and just basically that their outcomes are bad and there's nothing to do. And so this actually changed the direction and the focus of my research when I came here to University of Washington, and that's been my passion since then. But it's both the personal as well as just my clinical practice background and why I'm very passionate about this population. So one of the first things to know is that older adults are only about 13% of the US population, but they are about a quarter and a little bit higher now of trauma admissions. And so they're very disproportionately reflected in what is coming into trauma settings or into emergency rooms for care. And injury and hospitalization rates are increasing, and people will say, well, the aging population is increasing, it's just related to that. But even after adjusting for population growth, we are seeing higher rates of injury and hospitalization over time, and this is continued. And unintentional injury remains. It's been between like the third and the fifth, but it remains the fourth leading cause of death in persons 55 to 64 and those 65 and older. So it's trying to prevent things in the first place is really quite important. When we look at what is the mechanism of injury or what is the cause of injury of a traumatic brain injury in older adults, by far and away, the number one cause is falls. And followed by motor vehicle crashes and traffic incidents in which the older adult is often not the driver, they're rather the passenger, and that can have some different aspects to like how they're protected and in what type of vehicle they're in and pieces like that, the age of the vehicle. Interestingly, assault is growing as a cause of injury, and unfortunately in older adults, particularly in those 55 to 74. And so looking at ways that we can reduce interpersonal violence, people's risk of this occurring, but that is unfortunately also increasing. And the suicide attempt, self-inflicted, is the fourth cause, and then big broad category of kind of other. One of the pieces with falls that's also really important to think about is that a fall or a fall-related injury, and about one in 4, 1 in 5 older adults fall each year. And if you fall once, you're at an increased risk for falling. But a lot of older adults will respond to this by potentially developing fear of falling. And so they actually basically reduce their life space or how much they're going out in their environment. They're reducing risk taking. They might actually not exercise as more, not walk as more. And so that fear of falling can actually exacerbate the risk of falling. And so that needs to be addressed with the older adult to just understand what their activity is, how they've either constricted or maintained it, so that they don't perpetuate this risk of fall from having that fear of falling in the first place. And so that's also a really important piece to assess for when we're looking at injury risk prevention. I mentioned that the age-adjusted rates of traumatic brain injury are higher, and older adults have the highest rates of hospitalization and death from traumatic brain injury across all age groups. And they're more than 45% of all traumatic brain injury hospitalizations. And you can see that the oldest age group is the kind of brownish bar, and you see that it much outpaces, and these are the last available data from the TBI surveillance report that's available, but it's continued when we look at other data sources that we're seeing this. Part of this can be that people are recognizing that they may have experienced one. There was a lot of emphasis on recognition of traumatic brain injury, particularly in older adults in about 2010, 2012 through the CDC, trying to help family members understand what might be causes and to just, they fell, they look fine, but if they were on anticoagulation, like warfarin or something, just take them in. And so there might be a bit of positive effect from education, people recognizing this, but also the seriousness. The other piece is that when we call, and there's work going on in this space right now to classify brain injury a little bit better, but the vast majority of these are what we call a mild traumatic brain injury. There's currently 3 ratings: mild, moderate, and severe brain injury, but the vast majority of older adults experiencing a brain injury come in what is considered mild, or for those who know the Glasgow Coma Scale, between 13 and 15, so the higher end, they might have a motor deficit. We'll talk a little bit about why that might be a little deceiving when we talk about aging-related changes. But just to say that the vast majority are not in the severe category, they're mostly mild. Risk factors for injury in older adults, there are many, including comorbid conditions, and just making sure that we're actually looking at those and making sure that they're treated. Frailty is one, and also relates to fall risk for sure. Depression, untreated being worse than treated depression, issues with making sure that the heart is functioning appropriately, that the blood pressure is under control, that they're taking the time to, with orthostatic hypotension, taking time to adjust from like lying to seating position, seating to standing, so that they don't pass out and that doesn't cause head injury. Dementia, as well as looking at vision problems and incontinence, primarily stress or urge incontinence because of the need to get to the restroom quicker can increase risk of falls. Alcohol use because of effects on the brain, as well as effects on sensory and its depression effects. And then we certainly see a lot of medications that have been associated with increased risk of injury. And a lot of these in the medication category are on the Beers list. And so trying to avoid anticholinergics, for example, not having Benadryl for many, many reasons, but also thinking about those pieces and looking at that medication list and understanding, are there things that we should be looking at changing, deprescribing those pieces. There has been shown to be increased risk with certain antidepressants, mild increase, but it's not the same across all. And then diuretics, mostly because, again, the urge to urinate, and then looking at some of the antiarrhythmic cardiac medications, it may increase the risk for injury as well. And it could be related to the underlying cardiac issue that's trying to be treated. And it related to whether or not someone's getting adequate blood to their brain and oxygen to their brain. When we think about outcomes following traumatic brain injury in older adults, the literature consistently talks about, for a similar level of injury, that they have higher mortality than younger peers. They also have increased dependence at all severity levels. So mild, moderate, or severe, they may have changes in instrumental activities of daily living. That was one thing that my mother experienced, is that she couldn't navigate. We lived in a very small town, but couldn't navigate spaces. And so driving became an issue for her. So like transportation, she became more dependent on family members for. So looking at that increased dependence, they stay in the hospital and the ICU longer for recovery, which can result in higher cost of care overall. And then there's also increased risk of having, following the injury at a later time point, 6 months, a year, some neurologic decline, and that's worse than what might be experienced in a younger adult as well. And the literature's been pretty consistent about this for a long time. So one of the questions that we were asking were, what are the changes that happen that might create some of these implications? And so within the brain itself, there are neurochemical changes that happen with aging. So there's a reduction in a variety of neurotransmitters so where a neuron, a nerve cell, is transmitting to another nerve cell. And so having a reduction in that can like have slow transmission or lack of transmission. And so we see things like norepinephrine, acetylcholine, serotonin, a lot of them are reduced. And so that can take longer. So if I'm realizing that I might be falling, it may take a little bit longer for that signal to get back, like how to maintain my balance or how to do that. So that can be both on the injury side, but it can also be after the injury occurs and affecting that. There's also, we have, when the cells talk to each other, get single signal goes, and there's serotonin receptors. If it's, serotonin on another neuron that it's trying to signal to, and there's not as many receptors with aging. And so that can also delay the transmission or reduce transmission. There's also lower turnover. We have a receptor recover once it's used, it gets kind of recycled. And so this is also slower. And then also other issues. And so just basically thinking about, there are neurochemical changes that increase the risk for injury and can also cause delays in recovery related just to aging itself. There's also anatomical changes, which are really important. And one of the pieces is thinking about basically we have our brain cells or our neurons, they actually shrink over age, and the panel shows this on the right-hand side, that we see, we meet maximal, about our 20s, and then it decreases over time, this brain volume. This is related to weight, but it's also this loss of volume. And so we have that neuronal shrinkage within within the brain cavity. Also the loss of synapses, so the way that the cells are talking to each other. They're also, the dendrites are basically the projections from one neuron to the next, and so they have decreased length and width and reduction of the number that outgo. And then we also have some changes in some other supported brain cells like microglia, which can cause altered immune function. And so when an injury occurs or an insult occurs, there's a challenge to kind of clean it up in a way. And aging itself is a pro-inflammatory state. So which injury is an inflammatory state. And so can be a synergistic effect between what's happening with aging and what's happening with injury that can worsen some of the outcomes downstream. And then we have changes as we age related to our vasculature. Our particularly cerebral vessels become a little more fragile with age, just like when you're looking at folks' skin, the similar things are happening. And so the vessels are very vulnerable to rupture, which may lead to certain types of brain injury being more likely to happen with a similar impact or similar insult. And then we also have decreased autoregulation that occurs. And so this is where chronic hypertension will play a role, and basically it increases the older adult's risk to have susceptibility to the injury or have additional insult because the brain isn't getting enough blood and enough oxygen, and it can worsen the injury. Normally, we see with persons with hypertension, particularly chronic hypertension, that an acute reduction in their blood pressure, even when the blood pressure itself is normal. So, they were at I don't know, I'll just say like 160, and now they're 140, which stays in its normal range for an older adult. It can actually produce a lack of blood to the brain or ischemia, which can result in brain damage and brain injury. So regardless of what's happening with the actual physical, it can actually, with the response to injury, create that. And there are ways that we can monitor what's happening to cerebral autoregulation when persons are in the intensive care unit, but just someone coming into the clinic, it would be a little bit difficult or unusual that we would be monitoring something like that. One of the issues that I mentioned was because of those vessels being vulnerable to rupture, is that we see a higher proportion of older adults with subdural hematoma. And this is a head CT scan, and left is right, right is left on a CT. So what's showing up on the left-hand panel is really a right-sided injury, but you can see the white is a large volume of blood that is showing up from those veins, basically rupturing, having a tear, and they're bleeding out into this potential space. But what it's doing is there's so much blood volume accumulating that it's pushing basically we call this herniation, where the brain is out of alignment. And there should be these very large ventricles where we have cerebral spinal fluid, which is like the brain's cushion. But there's so much pressure on this side that it's actually pushing contents of the left side of the brain, right side of the brain rather, over into the left. And that creates a lot of deficits. One of the issues that happens with older adults is that loss of brain volume, the kind of atrophy that we see just normally with aging, can hide these symptoms. So basically, there's more room within this, we have a fixed skull, but if the brain volume's smaller, someone could be having a bleed and we don't see the symptoms until later. So oftentimes, when an older adult will have a change in their Glasgow Coma score that shows up, which is like what's happening with their eyes, are they opening it, are they verbally responsive, what's their motor pieces, so they could present either later for care because they don't realize that they actually had an injury that's resulted in any kind of changes, or it also can be someone looks like they're like a 15 because they look normal, but you could see a scan that has some, probably not this much change, but it does have changes, and there's actually blood there that's not being picked up because the neurologic exam that we're doing is not as sensitive for older adults. And so these are just particularly considerations with older adults because of the number of older adults. One, their physiologic changes with aging, but also many older adults are on anticoagulant therapy or DOACs or others, which increases the risk for potential for bleeding as well. And so just being aware of that intersection. We started to look at some of this work early on in 2006, and we're actually in the middle of doing the revision update to this for thinking about it, 20 years, what have we learned in the meantime? And unfortunately, it's still not a lot, and we're still finding some of the same issues result in some of the outcomes. So it's not just solely the older adult or aging that is affecting this, but it's also some of the things that we as healthcare providers or society bring to the table as well. So older adults in general get less aggressive treatment for similar conditions, and that is certainly true for trauma. And often older adults are not viewed as a candidate for a health promotion program, and so might not be identified as, you would be someone who would benefit from cardiac rehab or rehabilitation. And oftentimes, because of the differences, people will not include older adults in health studies. And so we don't know how some of the treatments would work in an older adult, if it's the same or different than in a younger adult. And so trying to look at that representation across the lifespan is The other piece that happens a lot is under triage, and triage is when an older adult presents for care, generally in the emergency department, and then we decide what's the appropriate level of care based on their injuries and based on what's happening. We know that under triage, people not receiving the correct level of care based on their injury increases with age, with rates reported to be as upward as 40%, as high as 60%. And then there are a lot of different reasons why that might happen. Part of it is the age-related changes that people might not pick up. They might be on blood pressure medication that is impacting how the assessment is being done. It might look like maybe they're hypertensive and it's just within the normal range, and so then they think that they're not having issues related to shock or other issues. Some of the other factors of the chronic diseases that they have can mask some of the issues or symptoms. And there could also be other injury factors. There's also personal factors too. Oftentimes it may be recommended that an older adult, say if they were injured, I don't know, like in Central Washington, which the only level 1 trauma center in Washington State is currently at Harborview here in Seattle. They might not want to leave their community. They might want to say, no, you might be recommending this, but there may be really personal reasons why the older adult does not want to be transferred to a higher level of care. And so just recognizing that that is also something that plays a factor, that they want to many times remain close to home and not necessarily be helicoptered over here to Seattle. There are some states, Washington is not one of them, nor are, to my knowledge, California or Oregon, but I haven't looked in like the last 6 months, but develop specific statewide geriatric triage criteria so that people end up at the right level of care for their injuries. And so they look at, age, different blood pressure thresholds, different oxygenation thresholds, different heart rate thresholds for an older adult to decide when they should be transported to a higher level of care or not. And so there have been some suggestions within some of the national guidelines that this also needs to be adopted. One of the other pieces that we found is that we don't necessarily know exactly what the history of the individual is, specific to their medical history, and how that might be intersecting with what we're seeing with the injury and deciding on appropriate triage. Also deciding if we're, what medications to put the person on, what have they been on, what might that be causing downstream regards to the injury. And we did a study where we actually looked at people for the whole entire hospitalization. And so it's not just the fact that, maybe someone can't respond to the answer, there's no family available. This was just not that first 24 hours, but it was the whole entire hospital stay. And over 10% of people had no data recording of their medical records in their history. And so that's a missing gap. What medications was the person receiving that they're not, that could be causing some withdrawal or actual harm to the patient? What things should we be treating that potentially we are not or not aware of, and how that might be interplaying. So really just emphasizing the need for getting an accurate history as soon as possible, whether or not it's from the medical record, we have Epic, and so using Care Everywhere to find someone's other records if they're coming to you from somewhere else, or if it's looking, trying to find someone who would at least know information about that if the patient themselves is not able to let you know their history. But when we did see that it's really common, and not surprisingly in older adults, that they do have chronic conditions, and that we should be aware of, very common that they have at least one and multiple, and often many more. But that absence can delay or complicate the diagnosis or treatment of the person and result in poorer outcomes. So that's an important area that is in our control, at least as clinicians, and we can deal with that. The other sort of example, and this is just one example that I could give many of the different types of care and where we're potentially falling a little short on where standard of care is that after a fall, the recommendation is that you're doing checking blood pressures, looking at orthostatics, doing vision checking gait and balance, and doing a neurologic exam to understand what are the pieces that individuals need, what are risk factors that we could prevent a fall from over 30% that we're actually doing to meet benchmark standards. And so just even doing better job on standard of care for assessment from in this case, a fall, because older individuals who have fallen once are at increased risk of falling again in the same year, and the likelihood of injury goes up over with the number of falls. We've also done work looking at the effective intensity of care with older adults and found that, and this was using guideline-based care to say what should a person coming in with a head injury receive. And then we looked at what older adults were receiving compared to those with similar injuries and adjusting for a number like injury severity and pieces. And we found that they were, even after controlling for injury severity, their sex, what diseases they have beforehand, that they actually were not receiving similar levels of care across this. And so just the things that we're not doing for people could be contributing to increased rates of death following brain injury. We also have done studies looking at what happens to the person with healthcare utilization using, this was from a national study of cost and outcomes of trauma. And what we found was, and this is just one sample, is that when we're looking across the age groups, we see significant differences on whether or not someone is rehospitalized. It was higher likelihood in the oldest 75 plus group that they were rehospitalized or they had a nursing home stay compared to younger. But they were much less likely to actually have a follow-up visit related to their injury. And so that is an area, why is that not happening? What could be the importance of that on outcome? Across the board, not a lot of people getting mental health professional visits, although we know certainly depression rates are higher. Some people can go on to develop post-traumatic stress disorder following injury, and it can have some increased anxiety, other sorts of things. And so this is low across the board, but certainly the lowest in the older age category of older adults. They're also, while they were more likely to receive paid home health care, this was also lower, but they were more likely in that oldest age group to receive care from friends or family. And so looking at social support systems that may be there or may not be there would be very important. But again, differential for similar injuries in what healthcare is being provided post-discharge and how that might intersect with the individual's recovery over time. There are some related to the hospital stay guidelines that have indicated that you should stop offering aggressive treatment to older adults if no improvement after 72 hours. This actually, when it's been studied, and this is the East guidelines, the no improvement is associated with increased risk of hospital mortality, but it is not associated with any difference in a post-discharge outcome. So if a person does survive to discharge, the fact that they didn't have recovery, the older adult didn't have recovery in the first 72 hours, does not make an outcome difference. So again, as our age bias is playing a role in, we're saying, oh, they're not going to do well because they're an older adult. And certainly I have anecdotally heard that from other providers of they're not going to do well because they're, 88 or whatever. And that's just can become a self-fulfilling prophecy. So thinking about that age bias that we bring and going back to the 4Ms, what do they want? What's the most important thing in their life? Is it that they want to be fully independent and functional, and understanding that? So having that as a context is really critically important in those kind of decision making and what treatments someone would or would not potentially want. I want to shift now into talking about clinical management of persons with traumatic brain injury. And I always like to say that, and others do too, management begins with prevention. Traumatic brain injury is different than, say, a stroke, in that stroke has drugs that you can use or interventions that can, if people get into the hospital on time, get to treatment on time, you can actually reverse or partially reverse the effect of that stroke by either dissolving the clot, pulling the clot out, if it's an ischemic stroke. With brain injury, a traumatic brain injury, what happens with the primary injury. There's no drug or treatment, although they've been trying to find this the whole time I've, over 30 years, there's been a lot of effort to look at what are the possible treatments. There is no treatment that will reverse from the primary injury. So whatever has occurred, and there's not a way to reverse it and bring that brain back. And so really, it's so important to start with prevention and really think about older adults and teaching and thinking about what are our opportunities to stop that head injury from happening in the first place. So with falls being the #1 cause, thinking about evidence-based programs for fall prevention, wherever setting that you're working with the older adult in, whether it's community-based. If you're a pharmacist, there's a Steady RX that's focused on pharmacists. There's also Steady for the hospital. Knowing that, like, looking at home safety, if people are community dwelling, the exercise is really critically important. And there's lots of different programs that are evidence-based for exercise for fall prevention, making sure folks are aware what the appropriate shoes are. It's not a great idea to wear socks in the house, for example. There's increased risk of falls and slips and trips. So just be like something as simple as that, or we're looking with the Steady long-term care toolkit, like what's the length of the garment that the person is wearing, like pants, because oftentimes over time, older adults will, just because of aging, the height it gets decreased. So oftentimes they're still in the same, 30 pant leg when it really should probably be a 28 to avoid that tripping and slipping. So looking at those as well, their clothing, and length of clothing. Driving safety, older adults over time, it's more difficult to turn to the left just because of the way that aging changes happen. So thinking about what are the accommodations that are needed for making sure, like, safety and driving if that's the person's driver. Also thinking about their driver safety programs targeting older adults, like through AAA and AARP, that can be helpful if individuals continue to drive. And helmet use if they're doing any activity, including skiing, which is a great sport here. And certainly if you want to ride the scooters downtown here in Seattle, I see no helmets pretty much in use. And so just thinking about really protect your head and have helmets available and wear them regularly. The other piece that we can do to look at prevention is look at that medication list. Are there things that need to be on it? Are there things that are increasing the risk of injury? And so just doing our good due diligence on checking those prescription lists as providers, pharmacists, nurses working with older adults, and then having vision checks regularly can also be helpful, as well as making sure that if people have impaired hearing, that they're having that corrected as well, which can also play a role in safety. So I mentioned that primary injury is a direct result of the initial traumatic event. And what can happen is if the brain is not getting adequate oxygen, for example, if we're having issues related to cerebral autoregulation, that actually can create progressive damage. So it expands the injury from what initially happened with the trauma to surrounding brain tissue or other places. And so one of the pieces that we focus on in management is preventing that secondary injury from occurring, making sure people's glucose are in control and stuff like that, that it's not going to exacerbate that primary injury. So again, TBI is not like stroke, but there are things we can do to stop it from getting worse over time. In our initial assessment, just mentioned that history is really important. We want to know how the person was injured, and if we know the duration and severity of how long were they out or unconscious, how bad was it, were they kind of like moaning and so they weren't fully, and then oftentimes you won't necessarily know because perhaps it wasn't witnessed, but if it is, that can be helpful in understanding severity and issues. You want to know like other symptoms, like what happened, remembering things. Did they not remember the event themselves? Or were they experiencing headache at the time? Were they dizzy? So understanding what was happening then, because that can also give clues and be important. You also want to understand if they had like a history of prior head injury, because that can actually increase challenges with management, but it can also make it more severe, and also depending on that window between the first head injury and when they're having this additional one. We also know that certain repetitive head injuries over time can lead to some neurodegenerative diseases. People may have heard of chronic traumatic encephalopathy, or CTE, that's been in the news related to like football players and rugby players. And so just understanding that may impact the recovery and may impact whether or not someone experiences that later neurologic decline. We also want to know what other conditions could be causing this. For example, or were they, were they out drinking, and this is, is it really they're passed out because of over intoxication, or is it passed out because of the head injury? And so understanding those pieces. Clear neurologic exam, doing mental status testing, understanding concentration and memory, checking their pupils, and looking at coordination. Do they have sensation intact throughout? And then following that initial exam, we want to repeat that until the individual returns to whatever their baseline is, if known. We also often, when individuals present to the emergency department or for care as an older adult with a head injury, there have been, because of the Glasgow Coma Scale lacking nuance in older adults to really look at that, what is most predictive on the neurologic exam for an older adult and whether or not they have an injury, whether or not it's significant, is often the motor score compared to what's happening with the eyes or the verbal. It's most predictive, but it's still problematic, and relates again to things like the age-related brain atrophy and some comorbid conditions. There is actually, I saw today, it was announced that there's going to be a new National Academy of Medicine conference in beginning of June, focused on new definitions for severity that came out of an NIH workshop. And so there should be more information if people are interested in like the topic of Glasgow Coma Scale, understanding severity, how should we be doing evaluation through the National Academy of Science and Medicine. One of the questions that comes up a lot is like, should we do imaging or head CT on the individual? And basically, there are two different criteria. The Canadian head CT rule is the one that is been found to be more specific and results in fewer CTs in younger adults. But this is the Canadian head CT rule, and they excluded anybody who had a neurologic deficit or a seizure, or if they were on anticoagulation. So those people all got head CTs when they were studying this. So anybody on anticoagulation got a head CT. So this is for people who are not on anticoagulants. So if they had at 2 hours, their Glasgow Coma Score was still not back to baseline, any suspected skull fracture, if they vomited, if they are not remembering the event more than 30 minutes, and depending on the mechanism of injury, did they collide with the windshield at a high rate of speed, for example. But one of the big criteria is age 65 or older, that this is just a baseline, and you don't have to meet multiple criteria, you just hit one. And so again, even those with GCS of 15 and older adults can have positive CT findings. Studies have found rates between 20 and almost up to 60%. And so pretty much in older adults, the rule of thumb is we end up getting imaging just to rule out that because the exam itself is not always on target for what's actually happening in the brain, and we want to be able to monitor it. For management, one of the pieces that we need to talk about with older adults and their family members is that, and anybody across the lifespan who has a traumatic brain injury, is that this is not something that you're going to wake up tomorrow and feel 100% back to yourself. It's really that the symptoms will resolve gradually, and it's generally within a couple of weeks. When it passes a couple of weeks for someone continuing to experience, say, new onset dizziness or new onset sensitivity to light, that's when we start to think it's more of a subacute sort of phase and thinking about pieces. Like I mentioned earlier, there is no specific drug therapy or treatment to treat the traumatic brain injury, the primary itself. Also, certainly, folks will get different types of surgery based on what is happening in the brain. They may get other methods to monitor what's happening inside the skull, but there's not a specific drug that we can do that's going to treat it and make it better. We want to avoid opioids in folks, and also sedating meds. And then thinking about what individuals are on: aspirin, anticoagulants, and alcohol can exacerbate the symptoms or prolong recovery. So doing education, if you're having pain, avoid aspirin. There's been a lot of debate around nonsteroidal anti-inflammatories and when is an appropriate time to restart for, say, if they have a headache, with not clear consensus on, is it 24 hours, is it 72 hours post-injury? And I will say that it can be very provider specific on when they might reintroduce like non-steroidal anti-inflammatories. But just also teaching individuals about what they should avoid, and then thinking about when to reintroduce if they were on anticoagulants, what that might look like. I'm not going to talk about like if they were on and concerned about reversal. There are great guidelines on what to do for if individuals were like on DOACs, what you should be doing, or if they were on warfarin, what you should be doing for those. One of the pieces is that people don't always remember what they're told. So even things like when you should resume your normal activity should be provided to them as written guidance, and either discharge if they're going home from the emergency department, or at the time that they're discharged from the hospital. And then we get to the subacute, which is, after a few weeks, to the chronic phase, which is more 3 to 6 months post-on. Then really we look at symptoms and really focus on the symptoms that the individual is experiencing, and we manage based on those symptoms. But one of the challenges that we see with older adults is that they will often, and this was actually a title of a paper, it's is it injury or is it aging? And oftentimes the older adult themselves will say, well, I think that this is related to aging, not so much related to my injury, but they have a difficult time parsing that apart, or like making their own determination. And so one of the pieces that we've been trying to understand is like what is normal about aging, what were you experiencing before, but what is also potentially the injury. And so there are differential symptoms experienced by younger adults and older adults. So headache is really commonly experienced by younger adults, but it doesn't even show up on the list of top 10 for older adults. Whereas they experience balance and fatigue at higher rates than their younger counterparts. Anxiety shows up as another one that's more prevalent in younger adults. This is less than 55 years, whereas memory difficulties and being bothered by the light can be higher. The memory difficulties will often be attributed to well, I'm just getting older, it's probably related to that, but it really may be related to the TBI, and we but still want to make sure that people aren't minimizing symptoms, and we're also managing those. So fatigue is really common. 2/3 of older adults have severe fatigue, and it can last for years and can be very debilitating. One of the biggest pieces to look at are what are secondary causes of fatigue that potentially we could be looking at that we're not dealing with. Do they have a sleep disorder? Are they depressed? Are there medical conditions that we're not adequately treating or aware of, like anemia? So making sure that we're looking at those potential secondary causes of fatigue. And then also making sure that we're looking for potential etiology. Is it physical fatigue, or is it like cognitive fatigue? I get, when I work really hard at my job for 4 hours, then I just find I can't go in the afternoon. So really understanding what it is. Things that we can do for older adults is that to manage the problem of fatigue is planning, putting the more active things earlier in the day, or if fatigue comes at certain periods of the day, like understanding that in our circadian rhythms, looking at a daily schedule, prioritizing, making sure that we're building in periods of rest that could be cognitive or could also be physical rest. So thinking about that. And then referral for physical therapy can be helpful, or cognitive behavioral therapy. Often it's a graded kind of aerobic exercise with a component of CBT, because often people won't necessarily want to engage in exercise or might have that experience of fear of falling. And so trying to get people like, oh, I'm not going to be more, like understanding that when I have this graded exercise, it's not going to be more fatiguing. So that's why there's a cognitive component to this, just to kind of get over some assumptions of this. Other problems include sleep issues, and certainly sleep issues are more prevalent in older adults in general, but we also see higher prevalence of insomnia and obstructive sleep apnea following TBI as well. And the lack of sleep can certainly intersect and make other symptoms worse. For example, like memory issues or other cognitive problems. It should be non-pharmacologic to start for treatment, looking at sleep hygiene, going over their routines with them. Cognitive behavioral therapy for insomnia can be very helpful. And melatonin is a possibility if the behavioral strategies fail, but again, avoiding drugs that are going to be sedating or on the Beers criteria, which many of the sleep meds are. Another common problem is memory. People will often report memory, like my memory is just not good, but it may reflect something instead, like their processing speed is slower. And so it just is taking them longer to get to what they actually know. And so cognitive testing can be really important in this, and either speech language pathology or occupational therapy can be very helpful with this, or if you have access to them. Neuropsychologists as well can do those. We certainly do them in research studies using like the NIH toolkit and screening for pieces, but not at the same battery level as specialists in the area do. Want to screen for those risk factors, looking at substance use disorder, looking at do they have a lower cognitive reserve to begin with? There is some literature that social deprivation or looking at resource deprivation can also create issues with memory. And so looking at those pieces, or do they have a history of a prior trauma? Interventions are restorative or compensatory. And so with compensatory being more commonly used and generally what folks will use to kind of deal with this, like I'm going to use my cell phone to set reminders that I need to take my medicine in X amount of time, or I need to do this. Post-traumatic headache, I mentioned like older adults don't experience this as much. We just want to make sure that for headache management, we're avoiding giving, if they do experience them, opioids or benzodiazepines, focusing on non-pharmacologic therapy. And there is no universal post-traumatic headache treatment. It often depends on the mechanism of injury, but a headache log can be helpful that someone can do to identify triggers or when they're coming on, or the severity. And so that can be helpful in the management as well of those. But again, it's very specific to the type of headache that people are experiencing, and understanding, is it, throbbing unilateral, is it bilateral? So that's where, again, the headache log and technology tools are great related to tracking headaches that can be used for this if that's a helpful tool for the person that you're working with. There are also within older adults, there are some increased risk of developing epilepsy or seizures after an injury, and that recur, that aren't just one-off, compared to younger adults. They often will have a delayed presentation. It doesn't happen like right away. It may happen in a couple of months. The newer agents like levetiracetam is preferable to like phenytoin due to the pharmacokinetics, the drug interactions, and just the cognitive side effects. So the newer agents with older adults are preferable to kind of the prototypical older agents. It can also, we know that there's evidence of a brain injury itself increasing the risk for an older adult developing dementia. So we can see that delayed cognitive decline. And there's been some associated risk with developing Parkinson's disease. They've also looked at other like ALS and other diseases. There's not really a connection to that. But there may also be new onset depression or post-traumatic stress disorder, although that's less common in older adults as far as the PTSD than in younger adults, and the likelihood of that development declines over time since injury. Some other problems that are common and particularly in older adults are the balance or vestibular symptoms. And when we look at postural stability, whether or not someone's ways can stay stable. That can be an indicator of recovery. It's actually something that gets tracked in athletes who have concussion, looking at postural stability and like, are they able to return to play or not, based on these are some of the factors. It's important to assess what's the contribution of vision in older adults. Is it corrected? Is it not? What hearing loss are they experiencing? Is that new, or is it, something that they had before and it was correct, they're wearing hearing aids, but did they have hearing loss? And that could also relate to the vestibular symptoms. And then really, again, doing that good look at the medication list for, is this something that could be a side effect of something that they've been on or that we put them on, and then referral for balance therapy, or if it's a vestibular issue, having them ENT can be helpful. Visual disturbances might be really uncommon. Other papers have said it's very common, but there are different things we can manage in environmental life if people are feeling like they're very sensitive to light, but it could be if they're having diplopia, using eye patches is like training for that to try and reduce it. The other piece that we see, and it doesn't get assessed a lot because this is often like the cranial nerve that doesn't get tested in cranial nerve testing, is their taste disturbance. But literature shown it's actually really common following an injury, when more common with an increasing severity of injury. But the taste disturbance, they can actually, some people, just like with COVID, can end up with anosmia. And then because you can't smell, your food doesn't taste as good. And so you can see impact on reductions in caloric intake. They can have weight loss. They may already be frail. And so really thinking about if you're always good to assess full cranial nerves, in my opinion, although I will say I leave it out sometimes too, but also making sure that we're monitoring their weight over time, and if needed, having a dietary referral, because there can be strategies, even if people aren't able to smell and taste as well, that might make food more like appealing from colors and other sorts of things that they can do, and also making sure that what they are getting are high caloric and high nutrition value versus low nutrition value, to maintain weight, because that can also be exacerbating with like loss of muscle and other pieces. And then just one thing is like, as far as the posture and balance, the usual pharmacologic agents that we would normally use for things like scopolamine that we would use are on the Beers list and do the anticholinergic effects, and so we avoid those for older adults. I forgot to mention that, but many of the usual medications used would be inappropriate or higher risk to use in older adults, and so trying to avoid them as well. And so with that, thank you, and we'll take any questions that folks have.
Thank you so much, Dean Thompson. This was outstanding presentation. I've learned so much, and I really appreciate your offering the distinctions for TBI and older adults versus younger adults. To that end, Sarah had a great question, which is, would childhood seizures or infant seizures be associated with the development of epilepsy in older adults? Is there research that would indicate that might increase their susceptibility?
Having childhood seizures, oftentimes I actually don't know. I think it's a good question. I actually don't know the answer to that. I know a lot of them are related to like febrile seizures or are one-offs, and so I don't know that that's been studied, but it's definitely a good question. I can get you the answer, Barb.
Other questions from folks? I would love to know or hear from attendees about what situations you've seen in your settings or in your professional lives related to TBI. What are the dilemmas that you've experienced, and what are maybe some of the ways that you have been challenged to manage TBI when you're working with older adults? Maybe Dean Thompson, you might offer a little bit of, while they're thinking, of your thoughts on some of the roles of different healthcare professionals. You've talked about nutrition and nursing and pharmacy and physicians and prevention. Other thoughts about this? We have folks, which I think is also involved, and you described in your talk, from physical therapy, from our AAAs here.
Yeah, it's definitely a team sport, 100%. Like, often work very closely with physical therapy colleagues, occupational therapy colleagues, speech language pathology colleagues on recovery rehabilitation, depending on the situation. And their expertise is invaluable in both the hospital setting with trying to get people ready to go to recovery. When we look at older adults following injury are less likely to go to acute rehabilitation following the injury. They're more likely, some of the docs I work at call it, they need a tune-up. So we're going to send them to skilled nursing to get a tune-up. So thinking about what that, working with social work on placements and pieces. And so there's definitely that aspect. The rates of recapture, so to speak, if someone can't participate in, the expectation is 4 hours of therapy to go to rehab, and or 4 to like 6 hours of rehab during the day, and we're sending them off and they're having difficulty getting to 3 hours, then oftentimes we won't recapture them back. And so really understanding what that is and making sure that they're participating, what are the issues with within skilled nursing. And so there's lots of areas there. Certainly the agencies on aging, supportive services when people do go home. Also great for thinking about prevention in the first place. And a lot of like great fall prevention programs, at least in Washington State, are done through those through the AOAs. And we've been I often see them on they call it Finding Your Balance at the Department of Health of the state of Washington. And they do a great newsletter.
Thanks.
So there was a comment.
That's helpful. Mary Zeitner has mentioned that she's involved in several aspects of sports related TBI, specifically motorsports, where the majority of drivers are adults and older adults. And unfortunately, unless it is very obvious, TBI is usually not given any thought. Do you know of any maybe obscure literature covering related issues specific to older adults?
In motorsports?
Yeah.
No, I think that would get classified under, it would be unlikely to be the motor vehicle collision probably, because I think of that mostly as road traffic incidents. But I don't know if it would be grouped under like other specifically. Because I think it would probably be, but I guess if someone said, I did road racing and ran into another vehicle, they might classify it. I think it's a little bit on the classification of the trauma registry and how it gets classified.
Interesting. And you had mentioned, which I think is a really valid point, having, like being born and raised in Alaska, I'm aware that a lot of times in order to get the appropriate services, people need to come down to Seattle, and yet that's problematic to make such a trip. So how are things for some of the whammy states in terms of getting to appropriate trauma center support if they're not willing to travel to Harborview?
So, yeah, there's definitely consultation that can occur if people want to remain in their environment. The issue also comes, maybe they do decide that they want to come down to the level 1 trauma, like they want to come to Harborview and get treatment, but then they go back to the community, which may not have the same supportive services, the same rehabilitation supports that the individual needs. And so telehealth has really played a bigger role in how do we make sure that individuals are getting the follow-up care that they need. We can certainly do, the assessment isn't necessarily the same, but like there's lots of activities going on around like tele-rehab and telepieces. So it's definitely something that people are thinking about. And then how do we make sure that folks have resources available to them? So if I had to drive 2.5 hours to get to physical therapy, how am I making sure that I'm able to access that, for example?
Sarah mentions it would be nice to see these tools and resources in rural areas such as small towns. She's not sure what all is offered in Montana, where I guess she's at.
So there is also one of the things I'll put a plug in for people who know about Project Echo. There is a Project Echo focused on traumatic brain injury where people can, providers or others can learn about different aspects, but they can also get consultation by presenting a case and then getting expert consultation. And the TBI Echo has been based here UW, but it includes folks from lots of other places, including rural areas, who participate and present cases. But it's similar to some of the other Project Echoes that are out there, like on
Yeah.
pain and pieces. And so that's another tool that people could use. There
Would
are
that be
also,
through the Harborview
it's not through
Prevention
the
Center?
injury center. I want to say it's actually through the Department of Psychiatry, but I could be wrong.
Okay.
Um, but um, but that is one that they've done. They have a lot of different Project Echoes related to that, but the idea is to get the expertise out and build capacity,
Mhm.
but also provide that case consultation when people are trying to do with this. The other thing that I would put a plug in for is most states have a brain injury association. And so that can be another resource. They have great like patient education tools. They have other resources like how to connect people to services they might need. And so looking for your local chapter of the Brain Injury Association it can also be a good resource. For a while, Harborview Injury Prevention Center was co-located with the Washington Brain Injury Association over on the Harborview campus. So I know about that as well. So that might be another resource for folks.
Oh, that's helpful. Thank you. Other questions, folks? I do have to say, I feel like you have touched on so many of the questions that I might have asked that we might have not have as much. Mary says there is a rural EMS echo and a rural emergency medicine echo organized through the Northwest Portland Indian Health. I guess I'm going to have to look up. Maybe I can find something and put a link next week to that would give a like what are all the echoes available because you
There's
want to.
a lot. There are a lot. It actually originated in New Mexico, so I know that there's a lot, and they've built out and hepatic disorders, all sorts of things. And so it's an overall great resource, especially if you're looking for
Right.
complex case consultation and connections. To be honest, like here, I'm going to have this is a person I can tap when I need to phone a friend.
Yeah, I'm aware that the Memory and Brain Wellness Center has a dementia echo, and the Northwest Geriatrics Education Center has a general geriatrics echo. But I keep hearing about more and more, and yet you don't maybe New Mexico keeps track of them all.
Yeah, I don't know. I don't know about that.
I'll I promise everyone I'll try and see if I can at least find a link to some sort of resource when you're looking for the possibility of an echo for issues that you might experience in your professional lives.
It does say I found an answer. It's from Google AI, so to take it with a grain of salt, but it does say having a seizure during a childhood can be a risk factor for developing later post-traumatic epilepsy. And I'm looking for and it is actually an actual article on PubMed, so might be valid. So good question. It looks like yes, it may be a risk factor.
Interesting. Other questions, folks? This is just excellent.
Well, thanks. And hopefully no one has to encounter too many people with TBIs. Thank you.
All right. Thank you very much, everyone, and have a good week, and I will see you next week.